There you go.
Great. All right. Hello, everyone. Welcome to our third CME session for PEPI, Project Echo for Primary Immune Disorders. As you all know, PEPI is focused on supporting rural clinicians through education and direct free consultation in regards to primary immune disorders. And we are focused in the Appalachian region of the United States, but of course, we're open to anyone in the world. And I'm grateful that we've had contact with participants from over 9 countries to this point in our just 18-month history. I want to thank the Creelan Clinic for sponsoring the CME program. And with that, it is my extreme privilege to introduce my dear friend and colleague, Dr. Monica Lawrence. Dr. Lawrence is an internationally regarded clinical immunologist. She's a professor of medicine and pediatrics and the designated institutional official and the associate dean for graduate medical education at the University of Virginia School of Medicine and UVA Health. Her contributions to the field span numerous foci, including clinical care, most importantly for patients with primary immune disease. She has national leadership roles that she's held at both the Clinical Immunology Society and the American Academy of Asthma, Allergy, and Immunology, among others. She's a tremendous educational leader and has, until recently, taking on her DIO role, was the training program director for the Allergy Immunology Fellowship at the University of Virginia. She has a number of scholarly works and publication. And so she really hits in every phase of the game. And with that, without further ado, it gives me great pleasure to introduce Dr. Lawrence, and she's going to be talking to us today about newborn screening for primary immune disease. Dr. Lawrence, the floor is yours.
Thank you so much, Dr. Ryder, for that introduction. I'm blushing. You may not be able to see it on Zoom, but I'm grateful for the kind introduction and for the chance to share what I know about newborn screening for severe combined immune deficiency with you all today. So let me get my slides going, and then I will say up front that this is not a talk that is going to take the full time. So there will be plenty of time for you all to ask questions or interrupt me if you have questions along the way or at the end. You can put them in the chat, and I think the rest of the team, Angie, will help share those with me. So let's get started and let's talk about newborn screening. First, for disclosures, I'm grateful for research funding support from folks listed there, and I serve as a consultant for Fermi and Cosmos. None of that directly impacts any of what I'm going to share with you today in terms of content. And here are our objectives. We're going to identify which assay is used to screen for severe combined immune deficiency, or SCID. We're going to understand and recognize the causes that can lead to an abnormal newborn screen from SCID, and we're going to describe what to do when you have an infant with an abnormal or critical SCID newborn screen. All right, so let's do a case. So this is a patient that I actually saw here several years ago. So this is a little girl who was born full term, normal birth weight. Newborn screen was sent, as it is, we'll get to in a little while, on all infants who don't opt out between 24 to 48 hours. She looked healthy and well and was discharged home and was doing great at home, breastfeeding well and physically looking completely healthy. So that newborn screen that was drawn, as I told you, on age 24 to 48 hours resulted 3 days later, which is a pretty typical turnaround time. And so I was notified by Paige from the Virginia Department of Health. I think I saw some of our VDH colleagues on the call, so thank you for joining, and thank you for all the work that you do. I received a page about a critical abnormal newborn screen for SCID. And so this is the form at that time. The form looks a little bit different now, but I received a call with this information as well as a follow-up fax. And this is sort of what it looks like. So let's walk through what all this means and what to do. So you can see here, it's pretty clear. It talks to you about a critical result for severe combined immune deficiency. And it's going to show you some things called TREC values and RNase-P values. I'm going to teach you what those mean. It's also going to give you some pretty helpful information that you need to know, like what the baby's birth weight is, which can be a clue as to whether that baby was term or not, whether the baby had received any blood transfusions, because that can impact the results, and whether the child is breastfed or not. All right. And so what did I do here? Well, first, let's talk about what is SCID, right? So if any of you are sitting there thinking, what disorder are we even screening for? So SCID is severe combined immune deficiency. It is the bubble boy disorder, if any of you all recall any of the kind of movies, or there was I think it was a John Travolta film with the bubble boy. But the bubble boy was a real patient. He was a real person. He was born many years ago in Texas, and here he is. And this was an infant whose older sibling had died from a disorder that we knew to be a absence of the immune system called SCID. And so when this infant was born, they immediately placed him in this bubble, and he essentially grew up there. And so the bubble was designed to prevent him from having any contact with the outside world, because they knew from his brother and from other patients that had died of this disease that he was incredibly susceptible to infection. And so, you can see him celebrating his birthday there. You can see him reading books. You can see him. Eventually, they made a spacesuit for him with NASA so he could actually walk around outside the bubble. But he lived his whole life in the bubble until he received a bone marrow transplant. Unfortunately, he died shortly after the transplant due to complications from EBV acquired during the transplant. But really, it's a example of something that was in the 1970s. That was state-of-the-art medicine for SCID. So we had nothing better to offer these children than to put them in a bubble and or know that they were not going to survive. So what is SCID? As I mentioned, it's an absence of the immune system that centers around one clear defect, which is all babies with SCID have absent T cells. So T cells are part of your lymphocytes that are important for fighting infections. Famously, many of you are familiar with HIV, which is an acquired deficiency of T cells. This is an inborn error leading to absence of T cells. And then depending on the flavor of SCID, they can have absent or present B cells or natural killer cells. All right, so what is the state of the art for newborn screening for SCID? Well, as of 2018, I'm thrilled to say that all newborns in the United States are screened for SCID. Virginia was sort of late middle of the pack in initiating screening for SCID. We started that on June 4th, 2015, along with many other states. So we've been screening now for about a decade. And the reason we screen for SCID is this. So in the past, before we started newborn screening for SCID, we would figure out that someone had SCID because they either died of infection, they had a family history of someone who had died or been infected by SCID. Those were the primary ways we figured it out. As newborn screening became more and more prevalent in the United States, you can see that we stopped figuring out that people had SCID by infection or by family history alone and figured it out because of newborn screening. I'll show you in a little while why that's so important. It's important because if we can diagnose them early, then we have some amazing opportunities to treat and really save these children's lives. In Virginia, every infant is screened for a variety of disorders. The list keeps growing slowly but surely. So every newborn is tested for this panel of disorders that's on the Virginia newborn screening list at 24 to 48 hours of life, unless the parent or guardian objects. It's done by a heel stick, and then you apply dry blood onto this Guthrie card in these little spots, which are then sent to the Virginia Department of Health, and they perform all of testing on this card. And the Virginia Department of Health has an amazing team of dedicated folks whose job is to help follow up on any of the abnormal results that come up and coordinate repeat testing or confirmatory testing, depending on what's appropriate. And so those infants are followed longitudinally until at least they have a satisfactory resolution and the diagnosis is made as either the disorder being present or not, or at least until the infant ages above 6 months. And newborn screening team, if anything I said there is incorrect, please feel free to jump in and tell me. So in terms of how we screen for SCID, what the actual test is looking for, it's looking for something called TRECs. So TRECs are the abbreviation for T cell receptor excision circle. And so I don't want anyone to panic looking at this and get back PTSD from when you were in biology class or in college or medical school. But this is what a TREC is. So when T cells, which are the things that are missing in all babies with SCID, when T cells are made, there is a process of what we call VDJ recombination, where different bits of DNA are essentially cut and joined together. And in the process of cutting and joining the DNA, some of the DNA is excised and is essentially junk or leftover DNA. That DNA forms a circle, which is called the T cell receptor excision circle. So the presence of a T cell receptor excision circle, or a TREC, tells you that there is a T cell there that is trying to be made, right? So it is essentially proof that T cells are there. The reason we use TREC, which is DNA, is that DNA can easily be extracted. It's stable, it can be extracted from that dried blood. Looking for the T cell itself requires actual live cells, which is much more unstable and difficult to look for. So this is a neat way of indirectly proving presence or absence of T cells and quantifying how many T cells are there. So the way we quantify how many T cells are there is we do PCR, which amplifies the DNA that's present in that dry blood spot. And so the number of cycles it takes to amplify the DNA is here on this x-axis. And the goal is to amplify the DNA to a threshold level. And so then you calculate how many cycles it takes to get to the threshold, and that value is called the cycle threshold. And so we are looking to see whether it takes a normal number of cycles to reach the threshold, because that implies that there's a normal or average amount of DNA, those T cell receptor excision circle DNA in that sample, implying a normal number of T cells. So if it takes more cycles, it means that you had less DNA to start with. Or occasionally we see that we don't have any DNA present at all, meaning no T cells at all. And those are the patients where we really worry about SCID. So this is just showing you what that looks like. You have a lot of garbage background, and eventually we start to amplify. This is 320 samples, so eventually we start to amplify. And you can see there's a range at which the cycles reach the threshold, and that's considered the normal range. This other line here is that internal control. You remember on the report you saw something called RNase-P. That's present in all cells, and so that's just telling you that the assay worked, that the lab technician put in all the reagents properly, pressed all the buttons, the machine worked, the test didn't fail internally. So that you know that if you don't detect TRECs at a normal number, it's not because something was wrong with the test. So it's an internal control to confirm. So as I mentioned earlier, the more cycles that you need, the less DNA you had to start. So it's an inverse relationship. That's important to mention because Virginia does it this way, but other states may do it slightly differently. So if you're reading newborn screening results, some states quantify the actual direct number of TRECs and calculate that out for you. Some states like Virginia calculate the cycle threshold. So sometimes it's inverse and sometimes it's direct relationship. So you got to read the report carefully to know whether you're looking for a high or a low number. But in Virginia, a higher cycle threshold, meaning more amplification required means lower T cells. And what does that look like? I showed you what normal looked like. This is what it looks like in SCID. So in SCID, you can see the RNase-P, the internal control, works normally. But in 8 known SCID samples, most of them, 7 of them aren't on here at all because they never reached that threshold, meaning there was nothing to amplify. One sample eventually got there, but well above what we would consider the normal range. So implying that in true SCID, essentially you'll see a cycle threshold that's kind of unreportable or very, very high, so above the normal range. All right. So, what as a physician or a provider in a clinic would you might see on that report? So, what you're hoping on a TREC assay is that you'll see normal, right? If you get a normal cycle threshold, that means you have normal numbers of T cells, right? And the newborn screening lab will only tell you that a child has a normal TREC screen if both the TREC cycle threshold is normal and also that internal RNase-P control worked, right? So they are going to do that work for you so you can trust that normal means everything is looking good. An abnormal result means that they found T cells, but it doesn't tell you, but they're reduced, right? So it could be anywhere from mild, moderate to very severe T cell lymphopenia. And again, they'll only report it as abnormal if that internal control worked. We'll talk about reasons for abnormal in just a minute. The ones I really want you to worry about are the ones that say critical or undetermined or indeterminate. That means that they were not able to really reach that threshold until very, very, very late. A lot of cycles are required or they never reached it. And that is a situation in which you have either true SCID or very severe T cell lymphopenia. And those are the ones that are really the most worrisome. And again, you need that internal control to work. And then last is something called unsatisfactory. And so in those situations, that's where that internal control failed to amplify. And so in that situation, the lab will request a repeat screen be sent so that they can make sure that they have the confidence in reporting out the result. Eventually, if they keep having repeat fails that are unsatisfactory, they will just report it out as abnormal so that it basically draws your attention that for a variety of reasons, this test is not working and you need to find another way to screen. So unsatisfactory is not the same as an abnormal. It just means the test didn't work. That baby could have completely normal TREC or completely undetectable TREC. We have no idea, right? So it just means they can't tell your result. All right, so let's talk about some things that come up a lot. So what happens a lot is that because the way that the newborn screening panel is done, if one's abnormal and you need to repeat one, frequently we have to repeat the entire newborn screen panel, right? So a child may have had a normal screen for SCID, a normal TREC done at day 1 or 2 of life, and abnormal on something else. And so the physician chooses or the provider chooses to repeat to follow up on the other thing that was abnormal. And then now on that repeat screen, the TREC comes back abnormal. And so a question I get a lot is, what do I do there? And so in that situation, what you have to remember is that the reference range was made on newborns, right? And in the neonatal time period is the time period in which your thymus, which is where T cells are being developed, is dumping out a ton of T cells. And so with age, normally thymic output is going to decrease. And so we expect in older infants that they may have less than the neonatal reference range. So the almost always advice that I can give you all who are looking at those results is that once normal for SCID, always normal. Meaning with rare exceptions, which do exist, but with rare exceptions, if you had a normal TREC screen in an infant at day 1 or 2 of life, that infant does not have SCID. Now, there are reports, and there are some very specific disorders where that's not true, but in general. The other thing that has come up a lot lately is patients that are testing positive for multiple rare disorders. As an example, one that I've seen multiple times lately is the newly added spinal muscular atrophy, SMA, and SCID, both coming up as positive. In theory, you can have two rare disorders, but likelihood of having two ultra rare disorders in the same infant at the same time is low. Um, so we suspect that that's unlikely to be truly the case that that multiple infants in Virginia are being born with both disorders. That being said, I can't advise you to ignore either one of those. So if you see either of those resulting as critical um, or as abnormal, you should take them seriously and treat them as if they're both positive, understanding that realistically, there's probably not the case that they have both disorders. All right, so what are some reasons in which you might have a newborn screen that's abnormal for SCID? So this is a huge study that was done early days back in California. So they looked at 3.25 million infants who had an abnormal newborn screen for SCID. And of those, so 3.25 million infants were screened. Of those, 562 had an abnormal newborn screen for SCID. And of those, so this is a very small percentage that end up even abnormal. Of those, only about a third ended up having true T cell lymphopenia on confirmatory testing. And of those with T cell lymphopenia, only a quarter ended up having SCID. So, as you can see, even when you do screen positive, ultimately only about 1 in 10 chance that you may even have SCID, right? That's okay. It's a screening test, right? We want to have more false positives than we do false negatives. But by definition, everyone who comes up with an abnormal newborn screen for SCID is not going to have SCID. Many of them are going to be normal. Many of them are going to have mild to moderate T cell lymphopenia, and a minority of them are going to have SCID. And I think that's really important because what you don't want is to imply to every parent that has an abnormal newborn screen for SCID that their baby has an ultra rare disorder and is going to die without treatment, right? On the other hand, what you also don't want to do, because some of them will have SCID, is ignore the result, right? So it needs follow-up testing, but it is not final confirmation. Sorry, that's just showing that graphically. All right, so why else might you be in that category where you have true lymphopenia? It wasn't a completely false positive, but it's not SCID. By far and away, the most common reason is being born preterm. So thymic output increases during gestation, peaks right after an infant is born, as I said, and then decreases with age. There are a lot of other immune deficiency and other syndromes that do also cause lymphopenia. So DeGeorge syndrome or 22q11 deletion syndrome, trisomy 21, ataxia-telangiectasia, a variety of other genetic disorders. And then things like secondary loss, so patients with hydrops or congenital heart disease or intestinal lymphangiectasia. Those are all reasons where you can lose lymphocytes and have secondary loss that can lead to an abnormal newborn screen. So this is just showing you what happens with gestational age to T cells. So early in the second trimester, you have T cells that are here. They sort of slowly increase until through the third trimester until term, and then fairly quickly start to decrease again. So the follow-up for that is that we do still screen neonates and extreme preterms that are born in the NICU, right? And so if you have a NICU baby, it's really not surprising that they're going to have an abnormal newborn screen for SCID, right? So what do we tell? Every NICU medical director is probably well versed in this, but what do we tell our NICU docs and our NICU providers? We say, in general, And this is just the UVA protocol. Other hospitals may have different, but the UVA protocol is that in general, if it's an abnormal newborn screen in a preterm infant, we just repeat the screen until the baby is full term or the baby's going home, just because we want to make sure that we don't lose that baby to follow up. If the baby becomes term and their newborn screen is still abnormal, or at any age, if the newborn screen is described as critical, meaning very low or undetectable, we do the confirmatory testing immediately, right? Because as you can see, even in extreme preterm infants, they should have T cells. They may be lower than normal, but they should still have some. So we take criticals seriously no matter which gestational age, but we take abnormals as something that we can follow with time until the baby becomes full term before we worry. All right, that was a lot. I'm going to go back to our case. So now you should hopefully be able to understand what that report shows, though. So I told you that baby had a critical result. It tells you helpfully on the report what that means. So if you have a cycle threshold or a TREC value cycle threshold that's less than 35 cycles to amplify, it's normal. If you're in this range where it takes 35.5 to 38.4 cycles to amplify, that's abnormal, meaning likely T cell lymphopenia. If it's over 38.4, you never get there, that's called critical. In this situation, they had no ability to amplify. And they told you they had a normal RNase-P value, meaning the internal assay control worked. And they repeated this 3 times. So this is a baby that I would say is at high risk of actually having true SCID. All right. I mentioned confirmatory testing. What does that mean, right? So you get this baby who now I'm worried does have SCID. What do you do? So to make the diagnosis of SCID, the criteria were recently updated. You need to do a test called flow cytometry and confirm the presence of very low T cells on multiple occasions, and have either genetic testing to support that diagnosis or no alternate explanation. There's a few other nuances, but just in general, that's the way to think about it. If you are managing one of these patients who has a critical newborn screen for SCID, here's what I'd like for you to do. We talked about what to do if it's a preterm or very low birth weight infant. We're just going to repeat. I should mention if a baby has a family history of SCID, obviously, then we're going to take it seriously that that abnormal or critical is likely true. But if it's a otherwise completely healthy, no family history infant, that's low birth weight or preterm, we're just going to repeat. Unless it's critical, at which point, no matter what the gestational age, we're going to send flow cytometry. If you don't know how to send flow cytometry, if you're unable to send flow cytometry from your center, which is very possible, if you get the flow cytometry and it shows low T cells, that's when we want you to be calling us, right? So Dr. Ryder, Dr. Borish, myself are all happy to take these phone calls and help you out from here. While you're waiting to talk to us or waiting for them to get into us, what should you be telling your patients? Really only 3 things up front are important. First is that if they do need blood, as is standard NICU protocol, but your baby may not be in the NICU, they may be a baby like the one I was talking about who's at home. If they happen to need blood, it needs to be CMV negative, irradiated leukoreduced blood products. That's important. They can't get any live vaccines. That comes up at age 2 months, right? So you could see how if an infant is lost to follow-up, it takes you a while to get the baby in for follow-up testing. It could get close to 2 months. You don't want to give them live vaccines. So no rotavirus at age 2 months. And you want them to not breastfeed until we have that confirmatory testing. That can be really upsetting to parents, but it's very important to prevent maternal transmission of CMV to the infant if the infant does have SCID. That can happen through the breast milk. All right, so for this baby, I told you day of life 1 or 2, screen was sent. Day of life 5, it resulted. Day of life 6, we got her in to see us. And we did some confirmatory testing in-house, and it confirmed that she had very low T cells, very low B cells, and normal natural killer cells. You guys are not immunology fellows, so I won't quiz you on what that means, but that essentially falls in this category of that diagram I showed you above, which are defects essentially in that VDJ recombination process that I mentioned earlier. We sent confirmatory genetic testing, which did indeed confirm a defect in a gene called RAG1, which is here and is involved in the taking apart and putting back together of the DNA. Okay, so now we have a diagnosis of SCID. We have confirmed low T cells. We have a confirmed genetic variant. All right. So what do we do from here? Some immunologists will admit these babies to the hospital and put them on reverse isolation, meaning everyone else has to wear gowns, gloves, and masks because the risk is not from the baby to you, it's from you to the baby. A positive pressure room as opposed to a negative pressure room, right? We want to keep this baby in effectively a bubble without actually putting him in a bubble. Some immunologists will isolate the baby at home, no visitors, no siblings. Everyone can't contacting the baby in masks and gloves. It all depends on the social situation and what is feasible. Also the time of year, right? Like the baby may not be as safe in the hospital in the middle of RSV and flu season as they are at home, especially if they're in a home with no other siblings. We start them on prophylaxis with antimicrobials, so antifungal, antiviral, and antibacterial. We stop breastfeeding because of the risk of maternal CMV. Some immunologists will allow it if mom and baby are testing negative for CMV, but that's very controversial. So in general, formula only. And we talked about the transfusions, the live virus vaccines. And then this is where we're going to really be sending them. This is where you really need to be calling in Dr. Ryder, Dr. Borish, myself to help get this baby to a transplant center. Bone marrow transplant is curative for SCID. If we can identify infants by newborn screening before they get infected, and if we can transplant them at a young age, 94% survival rate. So this is a very survivable condition if we identify it early and act quickly. If, on the other hand, we wait until they are older and present with active infection, which is how we used to discover that children have SCID, it's a 50% survival rate. And what's not shown on here is if you don't ever identify them and don't ever transplant them, the survival rate is essentially zero, right? So all of these infants without treatment and transplantation will die. So it's a disorder where we can take someone from essentially zero chance of survival to 94% survival if we act quickly and get them to transplant. So for our baby, we started her immediately on prophylaxis. We put her on isolation. We sent her for transplant. UVA currently doesn't do transplant for SCID, so we sent her to Children's National Medical Center up in Washington, D.C. She remained infection-free. She had a unrelated matched donor transplant at 3 months and 3 days, went home about a month and a half later. This is shared with permission. This is her at infancy, a beautiful, normal, healthy appearing little girl. This is her at day 50 post-transplant, doing incredibly well. And this is her meeting her donor in Disney World. And she is living a totally normal life now. So really, truly newborn screening for SCID saves lives. Just a little plug for those of you who want to be like this amazing human here and donate. You can join the bone marrow registry and be an unrelated donor to help others. So with that, I will stop. I promised you I wouldn't take the full time. So I will stop. And if there's any questions about newborn screen for SCID, I'm happy to answer them.
Anyone have any questions? You're also welcome to use the chat box.
I'll start with an icebreaker. Monica, that was fantastic. I mean, so rich and practical. I think you demystified a lot of the concerns there in a really complicated process. I think what you also painted was a real picture of both the clinical immunologist and team and the primary care team and the need to kind of couple the two. I think you, me, others, including Dr. Borish, here have managed these patients and have felt, the strong need for primary care involvement. And yet sometimes, not always, but sometimes there's a concern that maybe the patient should be completely turned over to the immunology team. I wondered if you could just share a perspective on just kind of how vital primary care teams are in the care of these patients, especially in situations where maybe the patient's family lives at quite a distance from the transplant center.
Thanks. That's a really important point. So yeah, absolutely, right? So these babies trust their pediatricians, right? They have never met Dr. Borish, Dr. Ryder, or myself, right? So you all are absolutely vital, right? And um, the person that they want to hear from and that they're going to trust in receiving this, what can be really hard news to process, is their pediatrician, right? And so frequently what happens is that this baby comes back with an abnormal or critical. The Department of Health will offer to help facilitate consultation with an expert immunologist and then call one of us, and we will reach out to you, the pediatricians, to give you advice. And then it's really, we partner with you to help communicate with the families about all of those recommendations that I made, right? So it's the pediatrician saying to the families, I need you to go see um, Dr. Ryder or Dr. Borish or Dr. Lawrence or whoever we get you in to see. And again, that trust is very important. I've had families where the patients don't want to believe it, right? They're like, what are you talking about? My baby doesn't have some horrifying genetic disorder that needs a bone marrow transplant. I don't believe you. And that's where your relationship with that family becomes so critically helpful. So yes, absolutely. It's a true partnership in getting these babies to care.
Anyone else? All right, well, I'm gonna wrap everything up. So this is for CME credits, and I'm gonna put a link in the chat box. It's very important that if you want to get your CME credits, please fill out that link. I want to be able to give you as much credit as possible for attending. So fill out that link. That'll come directly back to me and I'll be able to submit it. And it takes about 30 days for you to get all your credit. But we want to hear from you. We want to help you take care of your patients. So also in the chat box, I have our email. You can send de-identify patient information to us and we'll reach out to you and be able to help guide you and do a Zoom session with you on how to, treat your patient or what tests to draw. Any questions, we want to hear from you. And then also our episodes are recorded, and I also have in the chat box our YouTube video. So you can go back, you can hear more talks that we've given in the past, and you can rewatch the one from today. And without any further ado, I'll go ahead and end the session unless someone has a question. All right, well, you guys take care and have a wonderful day.